Good morning to our fellows and bariatric surgeons from the East Coast, West Coast, and around the world. We are here for our monthly May Fellow project on Do Limb Lengths Matter? We are joined by Dr. Benjamin Clapp and Dr. Saber Ghiassi, two of our experts in ASMBS and in bariatric surgery, well known internationally. A couple announcements. As a reminder, our ASMBS annual meeting is coming up at the beginning of June, June 8th through 13th in San Diego. Don't forget to sign up and make your hotel reservations. And then the third Thursday of every month, we have our fellow happy hour with Dr. Julianne Lloyd. And we have a great lineup for the rest of the year reviewing certain articles. So it's a great opportunity to get those academic juices going. Let's go ahead and get started. Dr. Clapp is joining us. He is a bariatric surgeon in El Paso, Texas. He's now on the executive committee for ASMBS and the chair of the research committee, and then president of the Texas Texas Association for Bariatric Surgery. We are excited to have him talk about how limb lengths matter and gastric bypass. Take it away, Dr. Clapp.
Thanks, Shane. Okay, so let me get my screen shared again. And okay, does everybody see the presentation? Great. Well, thanks for inviting me. This is my second time on the fellow project, and I like doing it. It's a lot of fun. I was tasked today to talk about limb length in the gastric bypass. So, I'm not going to talk about the SADI or the DS or anything like that. I think that's a completely different topic. So what we're going to talk about is a bypass and kind of what we know currently about that. Okay, so here's my disclosures. I do consulting for Medtronic Moon Surgical, which is a small robot startup. It's kind of an interesting robotic assist. It was at Sages this year. You might have seen it. And I get a travel stipend from Intuitive. And I was a fellow once. So here's where my laparoscopic instruments when I was a fellow. That was a long time ago. But, you get those, you make a big decision. Okay, might not play that well this early in the morning. But anyways, so our objectives today are to discuss the optimal limb lengths for a gastric bypass, a Roux-en-Y gastric bypass, because again, we could also talk about optimal limb lengths for one anastomosis gastric bypass. And what we want to talk about really and focus on is the problems that you can have with a biliopancreatic limb, and then what we should think about TAL, which is total alimentary limb length. That's the TALL acronym. And what are the problems if they're either too long or too short, or you don't get this right? We also want to talk about the role of limb lengths in revisions, because that's something where we have to think of the primary operation where we're thinking about like, okay, what is the optimal limb length for maybe weight loss or maybe comorbidity resolution, but also what about people that are gaining weight in a gastric bypass? As you get into practice, you'll see that more and more. People will come back, they're frustrated, they're gaining weight. And I think the optimal management at that point is a medication, but you can do some limb lengthening procedures to help them lose weight. So let's just remind you really quick of the Roux-en-Y configuration. You have the biliopancreatic limb, which comes down, meets the Roux limb to form the common channel. Now the Roux limb has a couple of different names, and depending on where you are in the world or the country, it can be just called the Roux limb, the alimentary limb, or the antral limb. The common channel and the biliopancreatic limb are pretty standard nomenclature. All right, so we're going to take a time travel back to 1994 when Whitgrove and Clark described the first gastric bypass. Of course, I'm not going all the way back to the open gastric bypass. I figured I'd start with the laparoscopic one since you guys are minimally invasive fellows. So it's interesting because if you look at that in 1994, their BP limb length was 12 to 20 centimeters, and the antral limb length was 75 centimeters. Average case time was 3 to 7.5 hours. So it's kind of like similar to what you fellows are doing right now. And it's about a 3-month, that was a joke. I mean, it's early in the morning. It's 5 o'clock in the morning for me. So I'm going to, all right. So yeah, so 7.5 hour cases and 3-month follow-up. But if you've ever had to revise one of these cases, which I've had to do, that limb length is teeny. And the other thing is that like, as you go through this, you'll find that as you're running the bowel, that 75 centimeters is often 40 centimeters. And it's very hard to reconstruct because you have these small BP limbs. So you're right up on the duodenum, right up on the fourth portion, and it can be very difficult. Okay. So how do we measure the bowel? Let's start with that. And how good are we at it? Because it's something that you learn. It's one of your skill sets that you learn in your fellowship, or even at FLS. I think they had the rope test. I don't know if they still have that. But how do you do it? And how accurate are we when we do it? So most of us are hand over hand. You can just robotically. It doesn't matter. But one thing you should do is as you're starting to learn this, you should use some sort of marked grasper. So I'm doing a SATI here. So I'm using an applied science grasper, which has a 5 and 10 centimeter mark on it. Now, I also know the length of my Storz grasper, which is in my left hand, the black one. I know the length of the silver portion of it, and I know the centimeter length of the letters of it. So it gives me some sort of visual feedback. Now, if we look at, yeah, novice versus experts, this is a nice paper from Israel. What they did is they had 10 senior surgeons measure the bowel, and then they measured it with a ruler. Well, with a measuring tape, like a known with a known distance. And what they found is that we're all a little shorter than we think we are. So we'll think it's 100 centimeters, and it'll be like 90 centimeters. And the longer that we tried to measure, like out to 200 to 300 centimeters, the more that line came off of ideal, right? So the longer you go, the more, and it makes sense, the more room for error there is. I mean, if you were going in a clock direction and you were doing some land navigation and you're aiming for true north and you're off by 3 degrees, the difference of you going a mile versus 100 miles is going to be very dramatic as you curve outwards, or not curve out, as you deviate from true north. Now, when we look at uh, fellows and surgical residents, what we can see here is this: we've found the same thing. Um, the experienced surgeons average less than 10% deviation from goal length, so that's about the same as the last paper, but it still resulted in a 30% of the estimated lengths with more than a 15% deviation. So 15% can be pretty dramatic, especially in something like a SATI bypass. It's probably a little bit more forgiving to have a 15% deviation. Now, even then, we saw a lot of individual deviation in between surgeons, especially as we went to those larger lengths, like the little triangle here represents 210 centimeters, and the circle is 150 centimeters. So experts are not immune from this problem. So the upshot of the last two slides, it takes time for you to become accurate. So just kind of constantly work on it. It's probably a good idea to measure your bowel, the total bowel length during a gastric bypass, and you'll see kind of as we talk about that. And also the longer the limb, the more off your count is, and get used to the distance of your instruments. So I'm showing here like the distance of that Storz grasper. You could also use a ruler, or you can use an umbilical tape or something like that that has a known distance. So those are other ways to make this more accurate. So what are the optimal limb lengths? And here's some problems that can occur if it's too short. You can get bowel reflux, obviously for the biliopancreatic limb. If it's too long, you essentially can get malabsorption, which can be pretty serious. So does limb length also affect weight loss? In which you probably have some answers in your mind to this already. And does limb length affect resolution of comorbidities? Can we change it just by modifying limb length? So if it's too short, bowel reflux, it can be a pretty significant cause of postoperative pain. This is an older paper. It's from Ed Felix. And you look at the pictures here, and you can see that if you're doing scoping somebody and you're in the pouch and there's bile there really shouldn't be. But he looked at 16 of his own patients, and some of them were other patients just from around, where he lives in California. Average time of presentation was long. It was, like 5 years. And they found that the alimentary limb length at revisional surgery was 37 centimeters. Now, that was longer than the traditional 45 centimeter limb that they used to treat alkaline reflux gastritis and B2 operations, because the gastric bypass and gastric reconstruction is not new. In fact, it was used a lot for ulcer disease. And I'm old enough that I actually have done B2s and B1s for ulcers. It was rare, but I've done a couple. So what they did is they lengthened the alimentary limb to 100 centimeters of resolution of all patients. So, if you're seeing that, go back and consider doing that. And it's hard to determine limb length until you're in the operating room. I don't think I've never found upper GI is really super helpful for that unless it's just obscenely short. So you kind of have to take them to the OR and be prepared for that. The other thing is I was involved in I was a witness or a consultant for the medical board once where this surgeon was getting sued because it was the technique of they were being sued for the uh, inappropriate performance of an operation, technical considerations. And the ruling was really short, and somebody had to revise it. And it's funny because getting ready for that case, and I didn't include this paper, I found a paper that showed that like even when you measured it with a ruler or a string of known, dimensions, it shrinks. So you'll think, boy, these surgeons back then really didn't know what they were doing. They didn't know how to measure anything. Well, in fact, you can demonstrate that the bowel will contract over time. Now, what if it's too long? Well, the effects of the alimentary limb and the biliopancreatic limb on a standard gastric bypass. Um, so what is limb length and what's the myth of limb length? So I thought this was a nice paper from Surgery in 2019. And what they did is they looked at distal Roux-en-Y gastric bypass, and they considered distal, and their definition was an alimentary limb of 150 centimeters or greater. So there's different definitions. So you need to know what people are talking about. So when you look at proximal Roux-en-Y gastric bypass, they use the lab study, which is the longitudinal assessment of bariatric surgery. And as you go through your career as a fellow and become an attending, you'll find that you will learn about the labs if you don't already know about it. What this was a multi-center trial where they had a couple thousand patients, and it's very well designed, and they are still following these patients. And so about once every year or two, you'll see a paper in the literature using the lab's data. So they had 1,700 patients. They actually measured the common channel in almost 550 of them. And then they categorized the biliopancreatic and alimentary limb lengths as less than 50, 50, greater than 50, and also the alimentary limb. And you can see that most people fall in these categories. And then remember, this is what their definition of proximal gastric bypass is. The common channel was measured actually in 54% with a grasper, with a string, and 37% of patients and with a ruler. So what they found is that if you exclude distal gastric bypasses, that there were no statistically significant associations between individual limb or common channel lengths or ratios and weight change or cardiometabolic outcomes. So that's kind of interesting. So, we have our pet peeves in our mind, we have our preconceived notions. And what they found is if you're doing just sort of your basic off the shelf gastric bypass, a BP limb of 50 to even 100 to Roux limb of 100 to 150, it really didn't change anything. Okay, but I want to talk about distalization next, and so I want to define distalization first, because you can talk about distalization just in a primary case or in a revisional case. So in distalization, a type 1 is the alimentary limb is divided and then anastomosed to the distal bowel to shorten the common channel and lengthen the BPL. So if we look at this picture right here, we can see that this is a type 1 distalization, right? If we go back, type 2 divides the biliopancreatic limb and moves it distally to shorten the common channel and lengthen the alimentary limb. So the difference in type 2 is that you're keeping the total abdominal length constant. And remember, I actually don't think I defined it. I should have defined it earlier. Total abdominal limb length is the alimentary limb, the Roux limb, plus the common channel, because that's what food is saying. So the way to think of total alimentary limb length is like, okay, what part of the bowel is food going through? Well, BP limb and this remnant stomach are excluded. So TALL is Roux limb and common channel. All right. So here, this is a nice paper that was in Obesity Surgery in 2020. And what they did is they looked at revisional procedures with conversion to either a proximal Roux-en-Y gastric bypass to a very, very long limb Roux-en-Y gastric bypass to a BPL. So here, if you look, you have a Roux limb of 150. They kept the Roux limb same length, and they increased the biliopancreatic limb with common channel of 100 centimeters. Kind of crazy, right? In this one, they took these and they increased the length of the BPL limit, keeping the tall constant, right? What they found, I just went over that, is that it's 6 years. Well, this is first the initial, then this is maximal weight loss, and then they start to gain weight again. So, almost, well, more than 25%, right? And then this is what they saw as they did their distalization. They could see more weight loss. They saw nutritional deficiencies as high as 14 to 17% in some patients with the BPL, Roux-en-Y gastric bypass. And they strongly advised to keep the total alimentary limb length at an absolute minimum of 300 centimeters to avoid the most severe nutritional deficits and high frequency of reoperations, because you're going to reverse these people. When you're not going to reverse them, you're going to reverse the limb length again. Now, what about length of the biliopancreatic limb? And so this paper looked at a standard BP limb, which was 50 centimeters. When I started out, we were doing 50 centimeters. I don't know, somehow I migrated to 75 to 100 centimeters now when I do this. Like, I think that I'm going to, go off on a tangent for a minute, since you guys got me up at 4:45 in the morning. But like, it's weird. And Shaina can probably think about this separate, but like, as we grow in our practices change subtly. And it's funny because it's not like, I don't think it's really super conscious, but you start to notice that, well, people are starting to lengthen their BP limbs. Maybe I should think about that. Or there's other little things in surgery that you start to do like that just kind of get this collective mass. And then next thing you know, you've changed your practice. And I don't know, you guys, we could talk about that in the comment section. But I think I was talking to Chuck Svensson yesterday about it. And we're like, yeah, we both have kind of done that as time goes by. All right, get back on track here. So they compared it to a long biliopancreatic limb of 100 centimeters, and they used a BMI of 40 to 50. So their standard is 150, 50, which is still pretty standard, to the long limb, which they considered 100 root limb, and 100 centimeter biliopancreatic limb. Now, the difference was statistically significant, however. And so when they looked at the standard versus the long at 1, 2, and 3 years, they did find statistically significant difference in weight loss, and actually in hemoglobin A1C, which starts getting people thinking about the metabolic response to limb length. And when you look at total alimentary limb length in the room-wide gastric bypass, this is a systematic review by Alice and Albert Rahman when she was a fellow there with him in Carolinas. They looked at 21 studies, 6 with comparative groups, so they compared 2 groups together, and 3 found that a shorter total abdominal limb length resulted in greater weight loss, and shortening the common channel resulted in more protein calorie malnutrition, which you're going to see a pattern emerge here. And they did find that longer BPL limbs had a better resolution of diabetes. Also, if they looked at the total abdominal limb length and it was less than 400 centimeters, there were 600 studies that investigated this. So you're talking about 100 to 150 centimeter common channel, almost like a DS or something like that. These studies reported significant issues with hypolipidemia, 13 to, well, really about a third of the patients, and actually up to 43% of them required limb lengthening. So they had to go back and do it again. And tall, with greater than 400 centimeters, lower limb lengthening rate later. So their upshot was decreasing the TLL, which is remember, this is a type 2 distalization. By increasing the BPL appears to be a more important factor for weight loss than increasing the root length. So the root length doesn't seem to be as important. If the total abdominal limb length was 400 centimeters and the common channel was 200, significant protein malnutrition and high revision rate occurred. And if the tall was closer to 500 to 600 centimeters, with a 200 centimeter common channel, it was better tolerated. So what about weight loss outcomes? This is the Dutch common channel trial, the Ducati, and this is actually a pretty good trial, and it's been reported on twice. This is the 1-year report, and then this is the 3-year report. And this is published in 2021 in obesity surgery, and they compared it to a standard gastric bypass. So there's a standard gastric bypass. You had a BPL 60 centimeters, root limb 150. Common channel they counted, but of course, remember that goes in the total. And the total, this is TAT, stands for total alimentary tract, just a little different nomenclature, versus the very long root limb, which the root limb was really long. It was like 422 centimeters on average, with a range of 210 to 730 with the short common channel. So if you look, the total alimentary limb length here is 522, and it kind of ends up being the same. But of course, the difference is the root limb. Well, what they found is the very long root limb did have a significantly greater weight loss, because this is total body weight loss. So it's going to be opposite from a graph like a extra body weight loss. And when you look here, when you follow it all up to 3 years, you have a statistically significant difference in weight loss, in excess weight loss and total weight loss at 3 years. So they concluded at midterm, 3 years, they had a significantly increased effect on weight loss of the very long limb, root limb, and compared to the standard, with a higher risk of overall complications, but they didn't really find any significant nutritional side effects. So they thought that you should maybe make a little longer one. Now, literature's all over the place, and I actually found this kind of a hard presentation to prepare for because it's all over the place. So whenever you see a problem like that, think of your friends at the ASMBS because the really smart people on the clinical issues committee they probably thought about this too. And I mean, you look at the people on here; they're all like brainiacs. I mean, Saber's going to talk next, and I know most of these people, and they'll take a long, hard look at a problem and they'll distill it for you. And I don't mind using my time also to give a shout out to Sages. Sages also has a very good way of looking at clinical issues and coming up with guidelines that are just or guidelines or consensus statements where they really distill these complex problems for you. So you could probably skip all the other stuff, although you should read it, and just kind of go to something like this. So what they found is that they surveyed ASMBS participants. They found the average length, and this is in 2023, so this is new. Average reported elementary limb length was 114 centimeters. The average BPL length was 48. Among international survey respondents, there was a little difference. That should be 126 to 150. And then the common BPL was 76 to 100. No standard common channel length because most people still don't measure it and think about percentages or anything like that. Now, in a primary gastric bypass, if you lengthen the alimentary limb up to 250 centimeters while keeping the BPL constant, it's generally resulted in additional weight loss and comorbidity resolution. When you have very long alimentary lengths, a short common channel is like 150 centimeters, you might get improved weight loss, but it's associated with higher malabsorption. So again, in most of the studies I talked about were included in this review. If we lengthen the BPL up to 200 centimeters in a primary gastric bypass without shortening the alimentary limb, again, we might get longer weight term, greater weight loss long term, and improved glycemic control. But we have an increased risk of micronutrient deficiencies. And that's the whole crux of the matter right now. It's like, where's the optimal lengths for each one? Because if we dial one up and we dial the other one down, we're going to get weight loss, but then we get the micronutrient deficiencies. And if we go the other way, it goes opposite. So that's why we need to find these optimal limb lengths. So additional studies are needed to determine this. Type 1 dislocation is a revisional procedure, lengthening the BPL length and shortening the common channel, can result in significant weight loss, but it carries a severe risk of macro and micronutrient deficiencies. So again, kind of what we know, dialing up or dialing down. And patients who undergo dislocation as a revisional procedure should really adhere to aggressive vitamin supplementations, kind of like think DDS, like do you really want to do on somebody that has shown up, one time in the last 7 years to your office, as follow-up? Or their vitamin supplement or their vitamin levels are already bad when you start. That might be something to talk to them about. So in conclusion, the very short common channel will require revisions at a high rate, up to 40%. Proximal room-wide gastric bypasses. A longer BP limb does seem to be a little better for diabetes treatment. Revisions, you should know the types of dislocations. Just in general, that's probably part of the body of knowledge a surgeon should have, a bariatric surgeon. And review the CIC guidelines, the clinical issue committee guidelines. It's the best to review the issue in the literature, I think. So if anybody got any questions, I think we're doing them at the end, right? Well, thank you. So that's what I have for my presentation. Let me stop sharing.
Thank you very much, Dr. Clapp. That was a fantastic overview of a very complex topic that I think does not plague us, but does evolve over our practice. I really appreciated that statement. Dr. Saber Ghiassi, who is actually one of the authors of the consensus statement from ASMBS, is our next presentation. He's going to be talking about do limb lengths matter in SADI and duodenal switch. He's currently an associate professor of surgery at Yale University, and he is the director of bariatric surgery at Fairfield Hospital.
Bridgeport.
Not wrong.
Bridgeport
Hospital. I'm so sorry. I wrote it down wrong. And we're excited to hear his area of expertise, considering how I think impactful that guideline statement has been to my own practice and to many that I've talked to.
Great. Good morning, everyone. And thank you, Dr. Hess, for the invitation. So I just wanted to make a couple of comments about Dr. Clapp's presentation. First of all, being older, I appreciated your surgical laparoscopic instruments. Mine were similar, but probably not as rusty. I'm glad that you mentioned the definition for the different limbs. I think for the fellows, I would suggest that if you ever do any kind of bariatric surgery that involves manipulating the bowel, it would be a good idea to measure the bowel and your limb lengths and document that, because there is a chance that in the future you may be revising that patient, and it's good to know that information ahead of time. Now, having said that, I don't routinely measure the common channel for my gastric bypasses, but after today, I think I will. And when I do measure the bowel for revisions or when I'm doing SATIs, I tend to do it 2 or 3 times, measure it 2 or 3 times using a ruler or a grasper. And I find that there is always a 20 to 30 centimeter variation when I measure the bowel, and I try to average them out and hopefully arrive at something that's somewhat accurate. So, I will talk about the historical limb lengths of biliopancreatic diversion with duodenal switch and the single anastomosis duodenal ileostomy, or SATI, which also has some other acronyms and names, but they're all variations of the same theme, and talk about some of the current data for limb lengths in these operations. So, biliopancreatic limb is pretty straightforward. The alimentary limb is the portion of the intestine that is in contact with food without the presence of biliopancreatic secretions. So rule limb, enteral limb is the same common channel, or the efferent limb is the portion of the intestine that is in contact with both food and biliopancreatic secretions. And then this TAL, or total alimentary limb, is the combination of the alimentary limb and the common channel. So this would be the entire length of the intestine that carries the food. And it's important to keep this in mind when we talk about limb lengths. Now, I'm going to talk about biliopancreatic diversion with duodenal switch, BPD-DS, or I'll simply say DS, which was first described by Hess in 1988, and then the SATI, which was described by Sanchez and Torres in 2007. But these two are kind of were as a response or a variation of the biliopancreatic diversion, which was described by Scopinaro in 1979. So what is a duodenal switch? It starts with a vertical gastrectomy, over a bougie from 40 to 60 French. The duodenum is then divided 2 or 3 centimeters distal to the pylorus. Then you start counting the ileum from the ileocecal valve, and somewhere between 50 to 150 centimeters, you're going to mark the bowel. This is going to be the common channel. And then you're going to count an additional 100 to 200 centimeter for the alimentary limb. And the ileum is divided at this point. You're going to make a side-to-side anastomosis between the biliopancreatic limb and the marked common channel. And then you can create a handstone or linearly stapled duodenal ileal anastomosis. And finally, you should close them as enteric defects, just like you would in a gastric bypass, to prevent internal hernias. Now, this operation was first described by Doug Hess out of Ohio in 1988. And this was a way of addressing the shortcomings of Scopinaro's biliopancreatic diversion, which was a horizontal gastrectomy. And so by preserving the pylorus and having a sleeve gastrectomy rather than a horizontal gastrectomy, the theory was that you would reduce the risk of marginal ulcers and dumping syndrome, and the longer common channel in Hess's operation would reduce diarrhea and malnutrition. So what Hess did was actually measure the total small bowel length. He used 40% of that total length as the alimentary limb, and then the common channel was 10% of the total bowel length. This operation was also reported by Picard-Marceau out of Canada in 1993. And for the fellows, it's really important to know the history of the operations we do. And actually, that description of doing the vertical sleeve gastrectomy as part of this operation was the birth of the sleeve when it was being used as a first step in a 2-stage approach to performing the DS. Now, Marceau described his operation as a 200 centimeter alimentary limb and a 50 to 75 centimeter common channel. So about 250 to 275 tall. Now, Hess, in 2005, published the outcomes 1,400 open cases. And these were a combination of primary cases and revisions. And this was presented at the 2004 ASBS, which is the name of our former society, ASMBS, at their consensus conference. So, when he measured the total bowel length in his patients, there was a huge variation, 375 centimeters to almost 12 meters. And this highlights the problem that we face. We talk about limb lengths, but if we're not really measuring the entire length of the bowel, then we're maybe talking about apples and oranges in different patients. Okay, in his series, the common channel was 50 centimeters in 23%, 75 centimeters in 69%, and 100 centimeters in 7.5%. So the most common limb length, the average was an elementary limb of 200 centimeters and a common channel of 75 centimeters with a tall of 275 centimeters. The excess weight loss was really good at 10 years. Leak rate and mortality was very low, but 37 out of 1,000 primary DSs required revision. 26 of those cases for protein deficiency or severe diarrhea, where the common channel had to be lengthened. And interestingly enough, there were 11 cases where there was poor weight loss, and he either shortened the common channel to improve weight loss or decrease the size of the sleeve. Around the same time, in 2005, this group out of OHSU and the Portland VA reported their results and the importance of the common channel in DS. And so this group, in 119 patients, they made the elementary limb length 40% of the total bowel length, just as Hess had done. But their common channels were divided into three groups, 150 centimeters, 100 centimeters, and another group that was 80 to 90 centimeters common channel. And the group with the 180 to 90 centimeter common channel had much better weight loss. So you can see that despite having much higher BMI, their weight loss was pretty significant. And they argued that in general, for the DS, a common channel length should not exceed 100 centimeter to maximize weight loss. And, when you look at, this is the group actually out of UNC, and they looked at the different lengths of common channel in DS and its effect on the resolution or remission of type 2 diabetes. So this was 341 patients that had DS, and they stratified them by whether they were insulin dependent or non-insulin dependent. They had a fixed elementary limb of 300 centimeter, but then they had three different groups of common channel lengths, 100 centimeter, 150, and 200 centimeter. Now, in the group that was not insulin dependent, the outcomes in terms of diabetes and hemoglobin A1C was similar. However, they found that in the group that was insulin dependent, the shorter the common channel, the better the outcomes for diabetes. And the improvement in hemoglobin A1C was independent of weight loss. So there was something about the common channel that had an impact on improvement in diabetes. Now, as you would expect, the rate of nutritional deficiencies were higher the shorter the common channel was. And this is a theme that you have heard from Dr. Clapp's presentation, and you'll see throughout my presentation. So shorter common channel and higher risk of nutritional deficiencies. And they said that the revision for malnutrition was similar between the different common channel lengths, meaning the differences were not significant. But as you can tell, 3.7% in the shortest common channel for revision, and there was no revisions in the 200 centimeter common channel. And this was great, a randomized control trial that this is out of Switzerland, I think, or Sweden. I can't remember. Sweden, actually. And so they randomized 47 people into DS or Roux-en-Y gastric bypass. And there was 13 to 17 years follow-up, which is pretty good. These patients had very high BMIs. And for their DS, they used an elementary limb of 150 centimeters and a common channel of 100 centimeters for a TAL of 250. The bypass was standard, a Roux of 120 centimeters and a BP limb of 50 centimeters. And it's not a surprise that the total weight loss was better for the DS than the bypass, and this difference was significant. But on the other hand, the adverse events were more common with the DS, and that difference was also significant. So we know from, studies that have looked at the long-term outcomes of the different types of operation we do, bypass, sleeve, and DS, that the DS by far is the most powerful operation for durable weight loss and addressing comorbidities, right? It's a great operation. But when you look at the number of these operations that are performed in the US, you see that the DS makes up less than 1% of all the bariatric surgeries that are done in the US. And this is the latest IFSA Global Registry report. So you see the sleeve, the bypass, and actually the one anastomosis gastric bypass, both in primary and revision procedures, kind of outnumbers all the other procedures. So the DS and the SADI fall into this other, and you can see that that makes up only a small percentage of operations that are being done globally. So we have to ask ourselves, if the DS is so powerful and the SADI also, which is similar, then why do they make up so little of the operations we do? And maybe this will give us a clue. Now, this was a 10-year follow-up, up to 20 years of follow-up of patients who had either BPD or DS. The DS patients made up 116 subjects in this study. And the 10-year follow-up was pretty good, 90%. That's really excellent to have that kind of follow-up. And this study was out of Switzerland. So 77% of these patients have had a band prior to being converted to a DS. The limb length for this group was a common channel of 100 centimeter and elementary limb of 150 centimeter for a TAL of 250. And for those who were older than 50 years old, they chose a longer elementary limb, which was 250 centimeters. And the idea being that you want to take less risk of malnutrition in those that are older. Now, their outcomes are pretty good in terms of weight loss. I won't talk about that, but I wanted to highlight that almost 30% of those patients required 40 reoperations. And the majority of them, 13 of those cases were for malnutrition or refractory diarrhea. 10 of those cases were for reflux, 7 for inadequate weight loss or weight regain, and then another 10 cases for other indications or a combination of these side effects. So this really highlights the problem with the DS is that, it's hard to get the operation so perfect that you get optimal weight loss with low risk of malnutrition or the need for revision. And maybe that is why the uptake of the DS has been so low. So it's a complex operation in comparison to other operations that we do. The risk of diarrhea, protein, calorie malnutrition, anemia, metabolic bone disease. Many studies with DS patients showed that vitamin D deficiency, increased parathyroid level, and lower bone density is an issue. And there's always a problem with fat-soluble vitamin deficiencies because this operation is malabsorptive, especially when it comes to fat and starches. And this was actually a study that Dr. Clapp was a part of. And when the ASMBS approved the SADI, and the SADI was included in the MESQUIP data, they looked at the first year, I think, that the data was available in 2020. and there were only 255 primary SADIs, so very small number. The SADI had higher incidence of perioperative complications than both the bypass and the sleeve gastrectomy. And the 38 outcomes of SADI were comparable to a traditional DS. But, they rightly highlighted the fact that these higher complication rates possibly could be attributed to the learning curve in the early adoption phase of this operation. And that's certainly very valid. So what is a single anastomosis duodenal or a SADI, or a SADI-S, which is, a SADI with sleeve? So this operation was first described by Sanchez Pernot and Torres in 2007 out of Spain. This was a modification of the traditional DS from 2 anastomosis to 1 anastomosis. So they made a duodenal ileostomy to a loop of ileum that was 200 centimeters proximal to the ileocecal valve. So a 200 centimeter common channel. Now, after a few years, they increased the length of this common channel to from 200 to 250 to 300 centimeters to reduce the risk of malnutrition. They proposed this as an alternative to the DS because of the shorter operative time. So theoretically, a reduction in the operative risk, lower risk of internal hernias or bowel obstructions, potentially similar weight loss and health benefits. Now, while we talk about the low risk of internal hernias with this operation, I have to say that that is not a risk of 0. And actually, I think at ASMBS last year, there was a great video of someone with a SADI who had an internal hernia, which was very difficult to figure out. And I thought that was a great video. So while the risks are much lower for an internal hernia, it's not 0. And then this operation, as I say, goes by a number of names, but they're kind of the same, a variation of the same thing. So here is the schematic. What you do, you create a sleeve gastrectomy. You disconnect the duodenum about 2 or 3 centimeters beyond the pylorus, similar to a traditional DS. And then you just count about 250 to 300 centimeter of the ileum from the ileocecal valve, and you make an anastomosis to that part. So this is pretty standard now. Now, I thought to highlight the outcomes, it's best to use the originators of this operation, Dr. Sanchez and Torres, and they have had several studies with short-term, mid-term outcomes, but this is the latest, which is their long-term outcomes of SADI. So 164 patients with 85% follow-up at 5 years, 75% at 10 years, so pretty good follow-up. And their common channel length was 200 centimeters initially in 50 patients, and then they increased that to 250 centimeters, 99 patients, and 300 centimeters in 15 patients. So initially, when they were doing the 200 centimeter common channel, the excess weight loss was almost 100%. So they had excellent weight loss outcomes, but a number of these patients required revisions to increase the common channel because of severe malnutrition. And that's why in 2009, they increased the common channel from 250 to 300 centimeters. And so the excess weight loss is pretty good, 80% at 10 years. That, really beats any outcomes of sleeve or bypass. The average stool frequency was 2.4, from 0 to 8 bowel movements per day in the first 5 years, and 0 to 6 with an average of 2.1 bowel movements per day at 10 years. They had 7.3%, 12 reoperations for malabsorption or malnutrition. So these were more common, obviously, in patients who had a common channel of 200 or 250, and nothing for those with a common channel of 300. But as you can tell, those numbers are small, so it's hard to draw really meaningful, conclusions from that. But still, shows you the shorter the common channel, the higher risk of malabsorption. And this was the outcomes of SADI, both as a primary procedure and a 2-stage, where the patients had a sleeve and eventually converted to a SADI out of Canada. 179 patients with 4-year follow-up of 67%, high BMIs for the primary cases. They use a 50 French bougie. And in the 2-stage where they just did a sleeve gastrectomy first, usually at 36 to 40 French bougie for the sleeve. Now, the common channel length in this group was 250 centimeters for both groups. So the excess weight loss was pretty good and similar, whether it was done in 1 or 2 stages. But the early post-op complications were 10.4% when this procedure was done in 1 stage versus 3.6% for 2 stage, which is why some surgeons feel like, in patients with very high BMIs, it's reasonable to give them a sleeve gastrectomy, lower risk, have them lose weight, and then perform a revision to a SADI, possibly a DS, with lower complication rates eventually. Now, in their group, both of those groups, the malnutrition rate was 5%. The severe malnutrition was somewhere from 3 to 5%, and 6 reoperations were done for diarrhea and malabsorption, where the common channel length was increased from 250 by 110 to 200 centimeters. And so, this was interesting. This was a group out of actually Baylor in Texas, where they did the SADI without measuring the total bowel length. So the common channel was 300 centimeters in those without diabetes. Those who had diabetes, they gave a common channel of 250, expecting better outcomes in terms of glucose control. But then they decided to start measuring the total bowel length and making the common channel 40%. And with counting the bowel, it turned out that the 40% gave them a longer common channel, which was the average was 309 or almost 310 centimeters versus the 269 for the pre-total bowel measurement group. And they wrote that the group that had the total bowel measurement and longer common channels had higher serum albumin levels. And although significant when you look, it's not like the albumin level is extremely low in the first group. So, you have to take that with a grain of salt. And this was a systematic review of SADI and 12 studies with 581 patients. And the common channel was 300 centimeter and 54%. So that was the most common, followed by 250 and 23% and 200 centimeter in 13% of patients. Average weight loss was pretty good at 2 years, 85% excess weight loss. Comorbidity resolutions were very good. Overall, vitamin A, selenium, and iron deficiency were the most common deficiencies reported, up to 50% of the patients. But I would say that if you look at a number of different studies, individual centers that report these outcomes, if they do report them, it's not only those, vitamin D, as I mentioned, elevated parathyroid hormone, and B12 are also some of the other deficiencies that you can encounter. Protein malnutrition in up to 34% of the patients when it was measured. Diarrhea was the most common complication at 1.2%. The average daily bowel movements were 2.1 to 2.5 in the 3 studies that have reported, and that was 213 patients. The revision rate of the common limb length for side effects was 2 to 7%. And, and the other study that I want to highlight is a study by Dr. Cottam, who's done a lot of the SADIs, was one of the early adopters in Utah. And he also does DSs. And so they did a retrospective comparison. Now, in their group, for the DS, they just divided a total alimentary limb of 300 centimeter by half. So 150 centimeter alimentary limb, 150 centimeter common channel. And for the SADI, they used a common channel of 300 centimeter. Well, no surprise, the DS had better weight loss, but SADI had significantly shorter operative time, length of stay, fewer perioperative and postoperative complications. So that was statistically significant. The nutritional profile was similar. Now, in another report, not this study, they actually reported 2 patients who had SADIs with a common channel of 300 centimeter, where the common channel had to be increased to 500 centimeter because of persistent diarrhea. So something to keep in mind, that even with a common channel of 300 centimeter, you can have patients who get diarrhea. And then there are a number of studies that have compared the DS to the SADI, and I will not go over all of them, but the common theme through all of these studies is that, and this was a meta-analysis, that the DS generally tends to produce better weight loss and possibly better for diabetes. Also, there are a lot of studies that show comparable outcomes in SADI and DS when it comes to comorbidities. But we know that the SADI has a shorter operative time and lower complication rates. And nutritional deficiencies may be more common in DS, but maybe similar. So you could make an argument that, SADI would be preferred over a DS. And this was interesting. A group out of Russia that reported their SADI and DS outcomes. These were all done open, so 226 SADIs and 528 DSs. So the elementary limb for the DS was 2 to 250. The common channel was 50 to 100, pretty standard. And their SADI common limb was 250. And they found that while the DS produced better weight loss outcomes, the rate of protein malnutrition and small bowel obstruction was lower for the SADI. The average stools were less. But 7.5% of patients with SADI had bile reflux, which is, you think with the pylorus intact, that should be very low, but this is what they reported. And actually, bile reflux accounted for 6 out of 9 revisions. And what they did is they revised these patients to a DS from a SADI to address that. And they argued that a DS may be a good option to address weight regain or bile reflux after SADI. So, and I think that sounds reasonable. So, what's the optimal limb length? Unfortunately, it's very challenging to say what that is, right? It's a balance between optimal weight loss against the risk of malnutrition. And Dr. Clapp already mentioned this. The other problem is, how do we accurately measure bowel length? Ruler, instrument, string, the mesenteric versus antimesenteric border, tension, no tension. We know that MR enterography is probably the most accurate way to measure the total bowel length, but it's very costly, and you can't make a case that, any patient that's going to have bariatric surgery should have an MR enterography. So there's a lot of questions to be addressed, but I would say that I can't imagine that many people are going to do a DS. As I said, the uptake has been very low, but if somebody is considering it, then elementary limbs should be around 150 to 250. The common channel somewhere between 100 to 150 for a total elementary limb of 300 to 400. And you can see a theme that's emerging, because when Dr. Clapp was talking about the total elementary limb of a bypass when it's done for revision or, a type 1 distalization, we see that patients tend to get into trouble when their total elementary limb is under 300 centimeters. So it's important to keep that in mind. And for the SADI, it seems like a common channel length of 300 centimeter is pretty safe. You get good weight loss with low risk of malnutrition, but you could also make an argument that maybe a common channel of 250 centimeters should be considered in those with diabetes, if you're doing revisions for weight recurrence possibly, or in individuals who have a short total bowel length, right? So if somebody has 4 meters of bowel total and you give them a 300-meter common channel, the weight loss may not be that great in those patients, and maybe you need to give them a little short of a common channel for the operation to be effective. So this is my talk, and I want to thank you, and happy to answer questions.
Thank you, Dr. Ghiassi, for such a comprehensive overview. The data has definitely exploded in the last couple of years in limb length specific to SADI and duodenal switch. So appreciate the review of the newer literature, especially from 2020 to 2023. I do have to make a comment. I love that each of you actually quoted the other in your talk. And so it's just a very collaborative and collegial environment. So knowing that we have experts here is fantastic.
He's an expert, so
I would not say I'm an expert. Yes, I have looked at the literature, but in the spirit of openness, I have never performed a DS. I have performed SADI, especially as revisions, but I've never done a DS, but I've certainly looked at the literature.
Yeah.
And I think for the fellows, I think the take-home point is most of you are not going to do DSs. About 3% of surgeons do DSs and SADIs. I mean, we talk about it at every meeting, but guess what? It's not, the adoption curve is not there. But you do need to know how to reverse it or revise it. And it's very hard to reverse it anatomically. You're going to have to think about distalization or proximalization and reverse it functionally. So I have a video at ASMBS this year about that, about a DS patient and severe malnutrition. So you got to wrap your head around these different limbs, and it's hard, and it's different from a bypass. You're a different quadrant, but that's what you need to learn, really. I mean, we'd like you to learn the DS and the SADI, but you need to learn how to manage these complications. That's what a fellowship is. Fellowship is learning how to manage complications.
So I think kind of to the questions we have, and I may run over just a couple minutes because I want to ask, with all this review of the literature, what are your limb lengths for a gastric bypass, and what is your limb length for a SADI? And if Dr. Clapp, you do a DS, I'd love to hear both of your guys' perspective.
Sure. All right. So as Dr. Clapp mentioned, I have increased my biliopancreatic limb length as I've, gone through my career. And I started off with, 25 to 40 centimeters, and now I do somewhere between 80 to 100 centimeters. And there is some truth to this mass effect. You build critical mass, and it seems like more people are doing that. But we have to say that it's not without scientific evidence. I mean, Dr. Clapp mentioned a number of studies that show when you increase the biliopancreatic limb, you tend to get better weight loss. And that hasn't been really as true with when you increase the rule limb length, a very distal long limb gastric bypass. So I've increased my biliopancreatic limb to 80 to 100 centimeter. My rule limb is about 100 centimeter. And for the SADI, I do the SADI as a revision, and I count the total bowel length. If the patient has, bowel length that's more than 5.5 to 6 meters, I give them a 300 centimeter common channel. And if it's shorter than that, I usually give them a 250 centimeter common channel. Remember, these are patients who've had a sleeve and are still super morbidly obese with a BMIs of 50 and above, usually when I do these. So want to be a little bit more aggressive.
Mm-hmm. Dr. Clapp, your perspective.
Very similar. I do a BP limb length of, I started out short, around 40, and I've gotten them to about 100. And my rule limb's anywhere from 100 to 120. For the SADI, I do a 300 generally, a 250 to 300. I'll do it primary or as a revision. There was a nice paper, though, about what you were describing with the percentage of bowel length. And it was published, I think, within the last year. And what they found, my uptake from that was that they were using, I think, 30%, and the distances were like within 30 centimeters of what you would do anyways. But I think it's probably a good idea to start thinking about percentages, because everybody's different. Like he was saying, if somebody has really long bowel, maybe it's a little different. We should probably do a percentage based versus an absolute, centimeter distance.
Yeah. Well, I agree. Definitely agree. But, here's the problem, and it's just intellectually, when you think, how do we come up with the best percentages? I mean, yes, Hess talked about a 40% out, but how did he come up with that? What was the thought process, and was there some real science that drove that decision? And I'm not sure we're there, but obviously we use historical perspectives for what we do now, but it would be great to have a great, study that looks at that, but it would be, I think, really, it would be very time and resource intensive.
Yeah, I believe there's actually going to be a presentation on percent bowel length at ASMBS and a session on it as well. So something for the fellows to look out for. I think to Dr. Ghiassi's point, that data is not there, but how do we develop the data? Because I think that's one of the important next steps for what we do is figuring out what's the ideal for our patients, whether it's bypass or SADIE, and then should we be changing up our limb lengths based on the patient, as discussed by both Dr. Ghiassi and Dr. Clapp. Question I want to ask: when you're for gastric bypass, if you're distalizing a patient, what decisions do you make for making bowel length changes? Dr. Clapp, I'll start with you. When you practice that, or do you practice distalization?
I don't really distalize that much. I very rarely use that. And I'll often find that I'm distalizing if there's a problem, or proximalizing like some sort of bowel obstruction or something like that. To address the elephant in the room, I mean, I think your best revision right now is going to be semaglutide, and the new medications. So I'd be happy. I mean, technically, I could go over how I redo a jejunal anastomosis. It's not difficult. There's plenty of videos on it online, but I'd like to hear what he has to say about that.
Well, I agree that, with the new drugs, GLP-1s, we're relying on them more and more. But I think there's still going to be some times when a patient may not respond, not have coverage, or, they just don't want to take medications. And that's so when I was working with Kellen Higa, he did a lot of the type 1 distalizations. And the way you do that is you basically divide the rulum at the jejunosteomy, and you move it downstream to increase the biliopancreatic limb length. And, we had a paper where we looked at that, and we thought that, the common channel should be somewhere from 250 to 350 with 100 centimeter rulum. So at least a total alimentary limb of 400 centimeters. And I've done a few of those in patients that really, I felt like their pouch was small. We couldn't resize the pouch. And it's a straightforward operation and seemed to be reasonable. And I've had mixed results. Some patients have lost weight, some did not lose much weight with that configuration of a 400 centimeter total alimentary limb. What I've done for a few patients, and I'm not advocating for this, but I felt like I revised them from a gastric bypass to a SADIE. And these are patients who are younger than 40, have had a gastric bypass 10, 15 years ago. Now they're in their late 30s or early 40s with BMIs of over 50. And I don't think a distalization is really going to get them there. So I've done a few of those. And I have to say, they're technically challenging. Out of the 5 I've done, I've had a leak at a gastrostomy, which I had to manage. So I wouldn't advocate for doing that routinely, but that's what I've done in terms of surgical management. We rely on medications more and more.
Yeah. I think it's an interesting concept. So dual board certified in obesity medicine, I'm all in on medications. I use them. I think combination therapy and thinking this longitudinally is so important. The challenge is insurance coverage. It's super expensive. And while Saxenda is going to lose its patent this summer, Ozempic has extended its patent, so it's not going to lose it for another at least 4 years, if not longer. They've got some really good lawyers. And so there are certain, if you look at 2-year data, I think there are some data showing that it's actually more expensive to stay on the medications. And then if you're on them, about 10% will not respond. And I think that's a really important point. People don't want to take injectable medications for the rest of their lives consistently. So the concern that I think bariatric surgery is going down because of obesity medicine, I think this is all a kind of ebb and flow, and we're going to be going back up, especially considering the cost. And working together collaboratively long-term is super important. And I've been playing around as we help people try to lose weight to improve their overall quality of life and health with medications. This idea of when do you make the decision to distalize versus reverse a bypass to a duodenal switch, I think is that's definitely not the cases you're starting out with fellows. Those are cases you're doing a couple of years into practice, maybe with a partner when you're first starting. But the decision making behind that is a challenging one. So I'd be curious, as you've gone through your 5 early learning, Dr. Ghiassi, how have you made the decision to go down that road? Besides the young, is there anything besides young, BMI, probably no acid reflux or gastroparesis issues?
Yes.
Is there anything, how do you say, I'm going to, go for the harder procedure than I'm just going to cut off a RU limb or BP limb? and plug it in further down.
Right. So really it has been, for me, it has been a matter of their age and the degree of their obesity, and I just feel like if the patient has failed a gastric bypass, which is a pretty good operation and they're still very young, and then I need to give them something that's really, really powerful, a powerful operation. And I'm not sure that distalization will get those patients there. That's really it. But, as I said, it's only been 5 patients where I've, converted from bypass to SATI. So I'm hopeful that if I do a few more, then I can follow them over the years and see what the outcomes are. In terms of weight loss outcomes, there are a couple that are now almost a couple of years out, and the weight loss outcomes are pretty good.
Mm-hmm. One final question, and then we'll give everybody time back. Do you guys do different limb lengths for your gastric bypass if you're converting a sleeve to a bypass for either reflux or weight recurrence?
Yeah, so I mean, I think that's important, and I would just kind of piggyback on what he said, that patient selection is so key. I mean, these people failed an operation, and we don't like to blame things on the patient, but you could tell when the patient's not being compliant with their diet, and any revision that you do if they're eating a bag of Cheetos a day is not going to work. So the patient selection is key. You got to work with these patients. So every one of them will come in and say, can I do my bypass again? Every one of them, but you've got to really be careful with that. But to go back to your question, yes, if you have a normal weight sleeve patient that's just suffering from, reflux, then I do a relatively short limb, probably around 75 centimeters for a root limb. And my BP limb is going to drop down to probably around 50 to 75. For weight, I'll do it like I normally do.
Dr. Ghiassi, final thoughts?
Similar to Dr. Clapp, I'm more aggressive with a longer BP limb when the revision is for weight regain or inadequate weight loss after sleep.
Yeah. Well, thank you guys very much for staying on 7 extra minutes. This has been a fantastic conversation. I always measure these personally based on how many screenshots I take of the presentations. And today was a 20+ screenshot day. So thank you guys for your expertise, your time, especially how early it has been for you, Dr. Clapp and Dr. Ghiassi. And we look forward to seeing you again during the question and answer for the 3 to 4 o'clock Eastern time for the afternoon, so we can get our West Coast team members learned up.
That's great. Thank you so much for wonderful presentations, and to both of you guys for coming back. I don't know if Dr. Clapp can hear us and can join by video. I thought this was such a wonderful topic for us to talk about now, because I think so many patients are needing revisions. And I think as the fellows going to practice, they really need to know more about doing this type of revision. While questions are coming in through the chat and through the Q&A, I guess I wanted to ask, first of all, just, off the cuff, sometimes we'll send patients to get an upper endoscopy, for instance, as part of their preparation for getting revision surgery. Do you think there's any benefit to doing any type of measurement on endoscopy? Do you think that's even closely accurate in terms of estimating bowel length for patients?
Hi, good afternoon. I'm not really sure if endoscopy's that helpful. I mean, it definitely is indicated for looking at a pouch, whether it's a gastric bypass or a sleeve. I'm not sure if they will be able to measure the length of the small bowel that accurately. I think so far we know that probably MR enterography is the most accurate way of doing it. But again, that's somewhat costly, and it's questionable whether it would be covered by insurance.
Saber, it's Maher. Thank you so much for the talk. I actually enjoyed your talk. I'm not sure if Ben Clapp is on the call or not, but he did talk about type 1 and type 2 distalization.
Yeah, I'm right here.
Hey, Ben, how you doing?
Hey, what's
on the
going
golf
on,
course, on the golf course, I see again.
I've got an MIS fellow with me. He's taking a vacation. And he's the one that's working for DiMaria right now.
Awesome, great. So
my old resident, so he came home and took him golfing.
That's awesome. That's good. I'm actually at the airport, so I apologize about the background noise, but I was asking Saber about the type 1, type 2 distalization. I know you mentioned that, and he was involved in the Clinical Issues Committee paper on limb length, many of us are actually currently doing distalization. And I personally use a total elementary limb length of 400 as my kind of like standard approach for distalization, which is typically a type 1 distalization. We used to do a type 2 distalization. We didn't get any weight loss with that, so we stopped doing that. And then the consensus was type 1 distalization, like you said, has better weight loss. Are you using 400, or what's the number that you go by? And from talking to other surgeons, what do you see like in the ASMBS arena? What kind of tall are people using?
Yeah, I think 400 is going to be pretty accepted, but I think the jury's out. And we were talking earlier this morning about using percentages of limb lengths versus, actual, hard and fast centimeters. So I think that's something that we have to look at. And I know there's a couple of papers that have been written about that. So I think that's going to be sort of an exciting way to look at this, instead of just thinking about 400 centimeters, maybe think about 30% total limb length, things like that.
Okay.
Yes, I think, there have been several studies that have looked at distalization, type 1 distalization, and I'm happy that you mentioned the type 1 and type 2, because type 2, which we refer to as very long limb, which is the long rule limb, has not produced as good a result. But the type 1 with type 1 increasing the obliopancreatic limb seem to work well. There have been, I reviewed several papers on this type of distalization, and it seemed that whenever the surgeons had done anything about less than 350, if they were 300 to 350, the rate of malnutrition and diarrhea was certainly much higher. So it seems like that's the sweet spot, somewhere around 350 to 450, and have to be very cautious about having a total elementary limb that's shorter.
Okay, talking about the common channel, one of the fellows is asking about the SADI, knowing that the sleeve conversion to SADI, typically you would use a smaller bougie. Most of us are using 36 French or 40 French bougie for the sleeve. When you do a sleeve conversion to SADI, do you actually change the length of the common channel? The standard seems to be 300. Do you make it different if you're doing a sleeve conversion to SADI versus primary SADI?
The issue is that when we are doing these revisions in people who have had a sleeve, they usually either have regained weight or they have not lost adequate amount of weight. So I would say that a lot of times their sleeve, even if it was done over a small bougie, if you look at it, by the time they get to revision, it's a little dilated. So it's usually not going to be that tight sleeve that was made initially, say, over a 36 or 40 French bougie. So it's actually, when I do these for revision, I do look at the sleeve, and sometimes if the sleeve looks too dilated, if there's retained fundus or anything looks unusual, I will trim it. And I still tend to go with a 300 centimeter common channel. But here's another thing. If you count someone's, you always should measure the total length of small bowel when you're doing these types of revisions, whether it's for gastric bypass, distalization, or for a SADI or a DS. And the thing that I run into sometimes is that a patient only has a total bowel length of, say, 380 to 450 or 500 centimeters. And then in these patients, I feel like if I give them a 300 centimeter common channel, that's really long for them. They have already shown their bodies are somewhat well adapted to holding on to weight and keeping weight on. You think somebody who only has 4 meters of bowel and has a sleeve should not really be able to remain super morbidly obese and have a BMI of more than 50, but yet they do. So I feel like it's okay to be aggressive in that type of patient. I tend to give them a common limb of 250 centimeters. Now, whether that 50 centimeters is going to make much of a difference or not, who knows? But if you look at the studies, it seems like that should be a little bit more powerful in terms of weight loss and control of diabetes or comorbidities.
There's a follow-up question from the fellow as well, asking whether you do any preoperative volumetric studies on patients before converting them from a sleeve to a SADI.
Well, I think your workup needs to include endoscopy as well as an upper GI when you're thinking about stuff like that. So, I mean, it's not true volumetric studies, but it's going to give you a good idea about the size of the pouch. I mean, I'm sorry, the sleeve, and if there's retained fundus or something like that. So I think you do have to do some basic workup, which would be that endoscopy in the upper GI. CT might help too.
Yes.
And as a follow-up question, are you guys seeing in terms of weight loss, in terms of sleeve conversion to bypass versus sleeve conversion to SADI, are you seeing better weight loss with sleeve to SADI compared to sleeve to bypass?
Absolutely. Yeah, absolutely. There's no question about that.
Okay.
I have to say that the weight loss for some patients when they're converted, the initial weight loss after SADI, conversion to SADI is slower. So, if you convert someone from a sleeve to a bypass, they'll have more rapid weight loss in the beginning. Because, you're making their pouch much smaller now, they're getting more restriction. Whereas sometimes when you don't touch the sleeve and you just do the intestinal bypass for the SADI, the sleeve is still the same. The patient can eat the same. Sometimes they even complain that, I get no restriction. I'm still eating the same amount of food, and they think it's all about restriction. And you have to just tell them to be patient, because if you believe the studies, and Dr. Kadam talks about this, that when you do these conversions, the weight loss is slower, but it definitely is more sustained. And, rather than having the weight loss plateau after, 6 to 12 months after the conversion, they'll continue to lose weight slowly for sometimes 2 to 3 years afterwards.
Yeah, I would go ahead, Ben.
Okay, well, I would just add, it's a little off topic, but when you're converting, most of the people here, and including the fellows, are not going to do that many SADIs and DSs. It's a very small percentage of what's done. And that percentage really isn't changing that much, despite all the talk. So if you're converting a sleeve to a bypass, I think you really have to focus on preoperative counseling with the patient, because they're not going to get better right away. If you're doing it for GERD, reflux, and dysphagia, I always tell the patients, look, you're going to have a higher rate of ulcers, higher rate of stricture formation. You might not feel like you're 100% right after the surgery. That might take months for your esophagus to kind of recover from the effects of the sleeve and the constant reflux. So I think it's just an important thing to talk to people about before surgery, set up their expectations, and then they're not that disappointed or calling your office every week like I'm still having problems.
We're already over time, but there's one more question in here I would like us to get to. It's more of a technical one in terms of when you're doing distalization, are you totally taking down the JJ? And have you seen any problems with like the distal stump becoming ischemic after you transect it there?
I usually, the easiest way to do this is that you go to the JJ. What I do is I just take a stapler and put it across the rulum right, at the JJ, make sure that I'm not crossing any staple lines. And then you just transpose that rulum, you measure what your common channel you intend to have. And then you just make a new anastomosis, and generally there is no issue with the anastomosis, the old JJ that's left behind. And then obviously you have to make sure you close the new mesenteric defect. That's typically what I've done.
Yeah, I do the same thing. So just basically chop off the rulum off the JJ and move it down, and which is what Ben was referring to as type 1. Type 2, we used to chop off the BP limb and move it down. Without taking the JJ down, because for the fellows, if you take the JJ down, you're left with 3 separate ends, and you have to reconstruct by doing 2 separate anastomoses, and you don't want that. You just want to do one anastomosis.
All right, it's 3:06 local time. Again, thank you guys so much. Yes, Ben, I can see that you really want to go golf. I hope you guys enjoy the rest of your weekend, and thanks again for showing up. We will have another session next month. All right.
Yeah, it's just hard work, I mean, to be a bariatric surgeon is a tough thing, and just all work.
You've inspired us, Dr. Clapp. I'm going to go outside and enjoy the sun.
Yeah, no,
And is always on the golf course.
One of my medical students, and then one of my residents. Now he's a trauma surgeon. God bless him, right? But Jisu's going to be a bariatric surgeon. So good, he's a fellow.
I use the robot.
Yeah.
Great.
All right, guys.
All
take
right,
care.
guys. Thank
Have a
you.
tomorrow.
See ya.
Okay, thanks. See y'all.